Hi, I'm Sarah Hurvitz. I'm a medical oncologist and professor of medicine at the David Geffen School of Medicine at UCLA. Until very recently, there was no real subclassification of breast cancer known as HER2 low breast cancer. It was either HER2 positive or HER2 overexpressing or amplified breast cancer versus HER2 negative breast cancer. And that's because all of our HER2 directed therapies were only demonstrated to work if the HER2 gene was amplified or the protein was overexpressed. Along came this antibody drug conjugate, trastuzumab deruxtecan, or TDXD, which is a HER2 targeted monoclonal antibody that has a cytotoxic payload connected to it that delivers the cytotoxic payload to HER2 positive breast cancer cells or HER2 low expressing breast cancer cells. The payload itself, the chemo component of this ADC, is released within a cancer cell and then is membrane permeable and is able to kill neighboring cancer cells, known as a bystander effect. And because of this bystander effect, TDXD has been shown to actually be effective in eradicating tumor cells that don't have overexpression of HER2, but have a lower expression of HER2 at the 1+ or 2+ level. These interesting preclinical and early phase clinical studies showing some benefit with TDXD for non-amplified breast cancer led to a large phase 3 study, DESTINY-Breast04, which evaluated TDXD and compared it against single agent chemotherapy in patients who had HER2 low expressing, but not overexpressing or amplified breast cancer. Those trial results were immediately practice changing because they demonstrated that TDXD was associated not only with a stunning improvement in progression-free survival compared to chemo, but also in overall survival. With very nice objective response rates seen even in hormone receptor positive breast cancer. On the order of half of patients had some type of response. So these data have placed TDXD in our standard of care guidelines now as a recommended therapy for patients who have HER2 low expressing metastatic breast cancer. You can use this drug in patients with hormone receptor positive breast cancer that is HER2 low expressing at 1+ or 2+, but not amplified, after exhausting endocrine therapy options, including CDK4/6 inhibitors, and after having at least one line of chemo. So this is not an agent we should be using in the first line setting or before endocrine therapy. For triple negative breast cancer, about a third of patients will have a low expression of HER2 and may be candidates for TDXD. The DESTINY-Breast04 study did include patients with HER2 low triple negative breast cancer. And although it was a small subset of the study, it did show very similar improvements in outcomes with TDXD compared to chemotherapy. So I think many of us would consider using this in that setting. The issue becomes we have another ADC, sacituzumab govitecan, for triple negative breast cancer. And many of us are using that ADC for TNBC in the second and third line setting. And so we don't know how these two agents compare to one another and whether you can sequence them. They do have very similar cytotoxic payloads. So we need more data to inform how to best use TDXD in triple negative HER2 low expressing breast cancer. But for hormone receptor positive, HER2 low expressing breast cancer, I think we've got very compelling evidence to use TDXD after one line of chemo.